Dr. Swafford, can you hear us okay?
I can. Can you hear me okay?
We cannot hear you.
You still can't hear me?
Yeah. Yeah, I tried that. Whenever we should. Still not able to hear you. Speakers on our end.
Can you hear me?
Yes, now we can.
Can you?
Yes, we sure can.
Okay, good.
One of us just wants to play it out loud, but we're both watching it.
That's fair. Let's see here. Can you see the slides okay?
Yes, we sure can.
Okay, well, if you can see and you can hear me okay, I can get started now if you'd like.
That sounds great.
All right, and at any point you guys have questions, just let me know. But I'm Kara Swafford. I am one of the stroke attendings here at UK, and today we're going to talk about acute stroke and transient ischemic attack. These are the objectives today. So we're going to talk about a lot of different things, but mostly it's just an overview of what I think is important to know. So I want to be able to teach you guys how to recognize and diagnose acute stroke using the NIH stroke scale score, as well as looking at imaging and understanding what you're looking at and how it relates to the patient. And then also the management of acute ischemic stroke, also the importance of timing and contraindications of thrombolytics, which would be IV TPA or tissue plasminogen activator. I know we were supposed to only focus on acute ischemic stroke and TIA, but I did want to briefly talk about acute hemorrhagic stroke as well. Just have a few slides on that to kind of be complete. And also I think that in medicine, you see that quite often from or in patients who have hypertension, or maybe they have a coagulopathy or thrombocytopenia from cirrhosis. Maybe for AFib, they're on an anticoagulant. So it's helpful to know the basics about hemorrhagic stroke as well. And then as I go through each case, I have a case for kind of each topic. I'll help to show you how to identify the mechanism as well as the etiology of each stroke type. We're going to focus on main types, as well as diagnosing and managing TIA. And then kind of at the end, I'll go over some primary and secondary stroke preventive measures. So this is something that we teach our patients, but it's also important to kind of realize as well. It gives you a really quick way to assess a patient who comes in either in the ER, they're on the floor, or maybe even in the clinic. If they're starting to describe some symptoms to you, I'm sure you all would quickly pick up on a concern for stroke, but this isn't something important that we could even teach our patients if they have history of stroke, or maybe they're following up with you after a recent stroke to go over their medications. We always teach B fast. So B is for balance. So if a patient has, and all this is important to notice that these are all acute changes. So acute is definitely the word that you're trying to pick up on when you're thinking about stroke. So a sudden loss of balance or coordination. Eyes, suddenly they have blurred vision, or they're seeing double, or they've had loss of a part or complete vision in one eye, or maybe even two visual fields or two quadrants in both eyes. Face would be asymmetric facial weakness. Arms would be unilateral arm, but don't forget about leg weakness, so hemiparesis. Speech, whether it's slurred or it's just garbled. Patients describe that in many different ways, but also mute. So mute can also be an aphasia. And then time means immediate medical attention. So when a patient comes in, the initial assessment that we perform for a suspected stroke, obviously you want to make sure you take care of the ABCs. You're focusing on their vital signs, which is part of that. Put them on telemetry to look for any arrhythmias, or maybe even concern for evidence for ischemia, because acute myocardial injury can be common in acute stroke as well. That finger stick glucose is very important because hypoglycemia, as well as very high blood sugar, not just hyperglycemia, but extreme hyperglycemia, can also be a mimic of stroke symptoms. Then you want to get IV access right away. And then for our history, we really want to focus on acute onset of any focal neurologic symptoms. It's very important to get that last known well time. So it's not when did the symptoms begin, that's the time of onset or the time that they were recognized, which may unfortunately be the time the patient woke up that morning. But really it's that last known well that's so important in stroke. So when you went to bed last night, you were normal, and then they woke up at 3 a.m. with symptoms. So their last known well was their bedtime. And if they're within 24 hours, it's really important to make sure that we stroke alert that patient if they're in the hospital or they're in the ER, or get them to the ER right away, because they could be a candidate for acute therapy like IV TPA, or maybe even a mechanical thrombectomy. We quickly go through the vascular risk factors, things that we're going to need to know, which may also lead us to identifying patients who are on anticoagulants, which are important, especially for TPA administration. And then we'll do a very focused examination. So just a very brief general exam, emphasizing cardiac and vascular exams, and then a focused neurologic exam. Most of our exam up front before we make a TPA decision or thrombectomy is getting that NIH stroke scale score. So here is the NIH stroke scale score. It's an 11-item scale. It's a lot to do, but once you do it frequently enough, you can learn to get through it pretty quickly and assess the patient within a couple of minutes. So we want to assess the level of consciousness of the patient by their appearance, and then we quickly go through and ask 2 questions and ask them to follow 2 commands. Best gaze is just horizontal gaze, so you're just checking for horizontal gaze. Visual is assessing their visual fields in both eyes, checking for a facial palsy, assessing drift in the bilateral upper extremities one at a time, same thing in the lower extremities, checking for limb ataxia in all extremities. Sensory, the same. Best language is you're assessing for their ability to identify objects, read sentences, checking for an aphasia there. Dysarthria is, you can pick up on that anytime throughout the exam that the patient's talking, but we specifically have them read a couple of sentences, and when they're naming objects as well, you can pick up on a dysarthria. And then extinction and inattention, which used to be called neglect, we assess for both tactile neglect, so you touch them on one side and then the other, and then both sides at the same time. And then also visual neglect. So you're giving them some stimulus in each visual field bilaterally, just one, I should say. And you're seeing if they can assess, pick up on one side, on the other, and then simultaneous visual stimulation. Of course, the most important thing to do is get that stat CT head. If you can't get that, if they're on the floor, for example, the neurology floor, if they're unstable or they just cannot quickly go down for a CT, you also have a MRI head as well. But of course, those would not be.
You what? Yeah.
Unless I can really get somebody up on the table and have them roll.
A, head and neck. We do for all of our stroke alerts here at UK, but that's not always standard. It doesn't have to necessarily be done to make a TPA decision. But you can consider an MRA head and neck if it's non-emergent, or if the patient, particularly if the patient has a contrast allergy. We don't really worry about renal function because the contrast can always be dialyzed out if necessary, if it causes kidney injury. If you're trying to rule out a thrombus to see if the patient's a mechanical thrombectomy candidate, then giving them a contrast would be considered benefit outweighs the risk there. So as far as stroke mechanism and etiology, so mechanism is just kind of like thrombotic, embolic, hypercoagulable, that sort of thing. Etiology is specifically what is that. So like, for example, cardioembolic mechanism, the etiology might be paroxysmal atrial fibrillation. So ischemic stroke accounts for 80 to 85% of all strokes. The rest are hemorrhagic strokes. Very common is thrombotic strokes. So those are your lacunar, small vessel disease strokes, for example, in the basal ganglia or maybe in the brainstem. And then you also have atherothrombotic. So there may be plaque rupture within the carotid or within an intracranial vessel with thrombus formation and then infarction from that. Embolic can be the same thing. So maybe you have plaque rupture in the carotid with embolization of that, either that plaque or maybe even that thrombus more distally into the brain. You can also have cardioembolic, either from LV thrombus because the patient has a reduced ejection fraction from a prior injury or cardiomyopathy. Paroxysmal atrial fibrillation is one of the most common causes as well. But then don't forget the paradoxical embolism in patients with a patent foramen ovale or PFO. So that might be a young patient who happens to form a DVT. You have paradoxical embolism through that PFO, and then they have embolic stroke. And then that along with the same lines is hypercoagulability. So that patient may be hypercoagulable, but there are also hypercoagulable states that can increase the risk of arterial thrombus as well. And then hemorrhagic stroke, by far the most common cause of that is going to be a hypertensive vasculopathy. So your lipohyalinosis, those build up in those tiny, tiny microscopic vessels. over time can lead to vasculopathy and makes those vessels very fragile, and they can rupture and cause hemorrhagic stroke. So can cerebral amyloid angiopathy. So that's a buildup of the amyloid protein in the wall of the vessel, makes the vessel very fragile, very friable, very easy to rupture and cause hemorrhage. Those most commonly cause cortical or lobar hemorrhages, whereas hypertensive vasculopathy, the most common are the deeper structures. So that would be like your basal ganglia, your cerebellum, and your brainstem. But hypertensive vasculopathy can also cause hemorrhagic strokes within the hemispheres as well, within the cortex or the lobes. And then don't forget about vascular malformation. So that's where, or even an aneurysm can cause subarachnoid hemorrhage. So that's why the CT angiogram is very important to help screen for abnormal vascular malformations or aneurysms. And then malignancy. So if you have either a primary CNS tumor or metastatic cancer to the brain, those can also cause hemorrhage. I'm going to start with a case to kind of lead us into the first example. So we have a 60-year-old right-handed man, has uncontrolled hypertension, diabetes, and smoking, comes in with sudden onset of slurred speech, right face, arm, and leg weakness. So complete right hemiparesis, slurred speech or dysarthria. And he has sensory changes in that same distribution. So hemisensory loss. His last known well was 2 hours ago at the time that symptoms began. So he was awake at the time that all this started. His blood pressure is 170/89, heart rate is regular 90, and his finger stick blood glucose is 184. So for him, his NIH stroke scale score is a 5. So you get points for the deficits that you have. A 0 is considered normal. So he gets a point for his facial weakness, drift in the right arm and leg. He has mild sensory loss in that same distribution, and he has mild to moderate dysarthria. So his NIH is a 5. He is 2 hours out, so a stroke alert red is called. The red is a new change here in the last couple of years. We've changed to a stroke alert red versus a regular stroke alert. That gets called out on the paging system, on the pagers. The red means they're within TPA window, which is 4.5 hours. If the red is left off and it's just a stroke alert, that means they're beyond 4.5 hours from their last known well, but they're still within 24 hours. So those are patients we're going to focus mostly on whether they have a thrombus or not, or a large vessel occlusion, and maybe a thrombectomy candidate. A red, they can be candidate for either TPA or thrombectomy. So here is this patient's non-con CT. So a CT head without contrast, you can see here, shows no acute intracranial abnormality. We don't see any bright blood, which would be considered what we call hyperdense. It would be almost as bright as the bone, somewhere within the parenchyma. So we don't see any blood. That's number one. And then the second thing is make sure you don't see any large areas of hypodensity or dark areas that would represent acute ischemia, which would also increase risk of bleeding if we were to give TPA if they had quite a large area. It would also make us question their last known well if we're already starting to see a hypodensity there, because it can take up to 4.5 hours, even depending on the size of the stroke, maybe up to 24 hours to start to see a stroke on a CAT scan, depending on the size of it. And then thankfully he gets a CTA of his head and neck, but just showed a little bit of plaque in his cervical carotid arteries, less than 50% stenosis, nothing high grade, no large vessel occlusion. So this gentleman, he's at least time-wise and based on his CAT scan, it looks like he is a candidate for TPA. He's within the 4.5 hour window. Based on his clinical presentation, his examination, we are concerned for an acute ischemic stroke. So of course, that's number one. You have to suspect that this even is a stroke in the first place to give TPA. You have to be over 18 or older to receive TPA. And then obviously the last known well has to be within 4.5 hour window. They have to have a measurable neurologic deficit based on the NIH stroke scale score. So maybe their NIH is a 1 for a little mild sensory change on the face or on the arm or leg. We obviously wouldn't want to give TPA for that because the benefit would not really outweigh the risk of having a hemorrhagic complication, just perhaps in case the TPA reversed that little bit of sensory change. But our gentleman here, he clearly with an NIH of 5, which is getting up to a moderate level of severity with his arm and leg weakness and his speech, it would be warrant TPA, or at least consideration of it based on those deficits. And then in order to give TPA, the blood pressure has to be less than 185 over 110. Once you give it, it has to be maintained less than 180 over 105. So that's something, if thankfully his blood pressure was below this, but if you have a patient who is very hypertensive, maybe in the 200s, we want to start working on that right away if we think we're going to give TPA. Also, you may find that lowering the blood pressure may reverse some of the neurologic symptoms that they're having. So that would make us think is more likely from hypertensive emergency rather than a stroke, but they're so similar, and one can lead to the next. So you want to go ahead and just treat the blood pressure and monitor closely. And then of course the CT has to be negative for hemorrhage, and it has to not show any non-stroke causes of the deficits either. So for example, a large mass, tumor, that could be the cause. These are the contraindications for TPA. So if the patient has any of these, we cannot give the TPA. So obviously unclear onset, if we don't have a good last known well, we have a time when the symptoms were recognized, but we don't know the last known well. So then they can't get TPA because of the risk that they may be well outside the window. And the longer you are outside the window, the more the infarct has evolved, the higher the risk of having an intracranial bleed secondary to that as a complication. Obviously, if they currently have an intracranial hemorrhage subarachnoid, or if you suspect one clinically based on like a thunderclap headache with neurologic deficits, even if the CT is negative, which it can be early on in subarachnoid hemorrhage, really err on the side of caution if you think that may be what's going on. If they have a neoplasm intracranially, now meningioma, for example, is extracranial, so that is not a contraindication. It's only intracranial. If within the last 3 months they've had any intracranial or spinal surgery, severe head trauma within that time frame, if they've had a GI malignancy or actively bleeding within the last 3 weeks, and then any type of bleeding diathesis. So platelet count less than 100, INR is greater than 1.7, and then PT and APTT are prolonged. So it's important to recognize here, even patients who are on warfarin, if their INR is less than 1.7, they can still get TPA. Same thing for a treatment dose of low molecular weight heparin. So if it's, for example, enoxaparin was given within the last 24 hours, but it was for DVT prophylaxis, then they're fine. It's treatment dose only. And then obviously if they're on a DOAC, so that would be like your rivaroxaban, apixaban, Pradaxa. If it's been taken within the last 48 hours, then they cannot receive TPA. We do not routinely check an anti-10A level because those levels don't really correlate well with their thickness or thinness of their blood. So it doesn't give us much information. And then we already talked about the blood pressure. If we can't get it down to that cutoff, we can't give them TPA. And then if you suspect infective endocarditis based on any symptoms, signs that you see, or if you hear a murmur, can't give it, or we shouldn't give it. And then if you either suspect an aortic arch dissection or you see one on imaging, you should make sure you rule that out before you give TPA. Now, all of these are warnings. So these are not contraindications, they're just warnings. So you have to, basically it would be consulting with the stroke neurologist to determine if these, the benefits outweigh the risk. So recent, that word is very broad. Recent, what does that mean? So you have to use everything in context. If they've had a recent ischemic stroke, if you see a large area of stroke already starting to evolve on the scan, if they have an unruptured or unsecured AVM, if they have aneurysm that is greater than 10 millimeters and it's not secured and it's not ruptured at the time, if they have a major surgery or major trauma within the last couple of weeks, if they've had any kind of arterial puncture at a non-compressible vessel within the last week, recent GI or GU hemorrhage, if they have a life expectancy of less than 6 months for any reason, including malignancy, if they have that bleeding diathesis that we talked about, if they have a hemorrhagic ophthalmic condition. So be really careful about patients who have acute vision loss. We have to make sure that we look in the back of the eye to make sure it's not from a retinal hemorrhage before we just assume that it's from a stroke and give them TPA and could worsen the situation. Acute pericarditis, if they have a known, or sometimes maybe they had a recent image and found out they have a left LV thrombus. If they have had a recent MI that has involved the left anterior myocardium. If they're pregnant or postpartum within the last 14 days, that's definitely a warning, but not a contraindication. If they've had significant vaginal bleeding, that's caused an anemia that's significant. If their glucose is less than 50 or greater than 400, sometimes that can be from a mimic. So we want to go ahead and try to treat that first and see how they improve, or at least that's considered a warning. You don't have to do that if you think that it's not all explained by their glucose. Some patients, we may already have prior imaging. So we have their MRI with their susceptibility weighted imaging that shows all those little micro bleeds or micro hemorrhages. If they have more than 10, that suggests they may have underlying cerebral amyloid angiopathy, and those patients are very high risk of having a spontaneous hemorrhage, let alone if you give them an anticoagulant or TPA. So we may want to err on the side of caution there, especially if they've had a symptomatic hemorrhage before. And then anybody with an NIH stroke scale score of greater than 35, if they're within that 3 to 4.5 hour windows, they're already 3 hours out, very large stroke is going to be suspected with an NIH that high. So obviously the larger the stroke, that tells us it's probably going to be more cortical. And if it's already 3 hours out, they're going to be high risk of bleeding. So once the patient gets TPA, remember we have to keep that systolic blood pressure or just the blood pressure less than 180/105 for up to the first 24 hours. Now the risk of administering any antithrombotic therapy within the first 24 hours, either with or without any type of thrombectomy, is uncertain. So if the patient happens to have a brand new stent and they have to continue that antiplatelet therapy, or maybe they're having a STEMI and cardiology wants to give an anticoagulant, we really don't know what the risk of giving that within that first 24 hours after they've received TPA. We really don't know what that risk is. We know there's probably going to be increased risk of hemorrhage, but we have to do what's necessary for these other diagnoses as well if there's a substantial risk in withholding that treatment. So unfortunate complications of TPA, the most common is going to be hemorrhage, even though it's not that common, but that's going to be one of the most common types of complications if they have one. Thankfully, it's very rare, not rare enough. So it immediately stop the TPA if it's still infusing, especially if that patient has a sudden neurologic change. Just that CT head to rule out hemorrhage. If they have one, you want to make sure that you get CBC, coags, fibrinogen level, type and cross, because it's not always just intracranial bleeds. They can have extracranial as well, especially if there's a surprise GI, maybe they have an ulcer and it's been bleeding and they weren't aware of it. And then, of course, we consult pharmacy to help us reverse it with tranexamic acid or TXA, either with or without cryoprecipitate. And then another common complication is angioedema. So the rate of that is about 1 to 2%. So it's very rare, but we typically see it in patients who are on an ACE inhibitor. So maybe they're on lisinopril at home, they get TPA, and then they start having angioedema, which can be quite severe and may require admission to the ICU with intubation, or at least close monitoring of that. So of course you want to hold the ACE, stop the IVTPA if it's still infusing, give Benadryl, and maybe even steroids. So if the patient doesn't get TPA, the American Heart, American Stroke guidelines say that we should let them be permissive up to the first 24 hours. So that's 220 over 120. It's quite high. And then you can start to lower it by 15% within that first 24 hours. And by that time, up to a couple of days out, our goal is to get them down to normal tension. Really, the reason that we're allowing for permissive hypertension is in case there is an ischemic penumbra around the core infarct, and that's what we're trying. And then everything that follows after that, of course, we want to assess our patients with a bedside dysphagia screen if there's any concern with that, or if we decide to delay it for a formal dysphagia evaluation. Those things are very important before any PO intake for that patient, because dysphagia is a very common complication of stroke. We want to have early initiation of antithrombotic therapy. So that's going to be typically an antiplatelet like aspirin or clopidogrel right away, immediately, if we're not given TPA, if there's not a hemorrhage, or within 24 hours after their TPA. DVTs are very common in stroke patients. Obviously, if they're immobile, laying in the bed, because of their hemiparesis, for example, DVT prophylaxis is going to be very important. And then we know that uncontrolled hyperglycemia can cause poor stroke outcomes in our patients. So we really want to make sure that we treat any hyperglycemia, keep it 140 to 180, but not over-treat, because hypoglycemia has its complications as well. And then we want a quick assessment as soon as possible with PT and OT, because we know that early physical therapy is what helps our patients most, is getting them therapy, getting them to rehab if necessary. Over the long term, their prognosis is much better if therapy is initiated right away. And patients even with minor symptoms, so you may think that their leg weakness is very minor and maybe we don't need PTOT, but we always get it on all of our stroke patients, because we don't take the patient up and down stairs like PTOT does. So there may be some subtle weakness there that could affect the patient once they get home that we didn't recognize in the hospital. Now, not every patient with a stroke needs a cardiac evaluation. Really, we had a protocol change in 2018 that the only reason we should be getting an echo is if the patient has new onset AFib, or if they have had an embolic appearing stroke. We think they may have endocarditis. So any patient who is over 60, has known AFib, or had a lacunar small vessel disease stroke, echo is not required. A patient who is over the age of 60 and has had an embolic stroke of undetermined source should get an echocardiogram to screen for that as a possible mechanism. Anybody with new onset AFib, we like to get an echo on. Of course, anybody with acute MI, or if we're thinking they may have endocarditis. And then for all patients who are less than 60, we consider that our younger population. If they have had an embolic appearing stroke and we don't know what the source was, we like to do an echo with a bubble study to screen for a PFO, especially if they don't have a lot of other vascular risk factors for stroke. And then cardiac monitoring. So we recommend this a lot for our patients who've had a embolic appearing stroke and we're worried about paroxysmal atrial fibrillation. So because of that recent study, the Crystal AFib study, it showed up to 84 days. The median was 84 days before atrial fibrillation was detected in those patients. And they all had an implantable loop recorder. So we know that the Holter monitor for just 24 up to 72 hours, if it's negative, it's not really a sufficient screen for paroxysmal AFib. So we will try to do the longest that we can is a 30-day. If that 30-day monitor is negative, then we offer the patient to be seen in cardiology to consider implantation of a link, which is the implantable cardiac monitor, to continue to screen. And whether we do that or not is really how strongly we feel that AFib is their mechanism. And if by detecting it, it would change their management. And then I think that's all for that. So back to case 1. So this is our patient who had the right hemiparesis, the right sensory disturbance, and dysarthria. This is his MRI. So you remember his CT looked negative, but when we do the MRI, we see a small area here. This is the diffusion weighted imaging. We see area of restricted diffusion kind of in the left posterior limb of the internal capsule. And on the flare, we also see a hyperintensity there. See some scattered areas of white matter disease as well. So overall, he's had a very small stroke. But he does have some underlying risk factors: uncontrolled hypertension, diabetes, and smoking. And based on those risk factors and the location of the acute infarct and the areas of white matter change that he already has, looks like he has small vessel disease, and that's likely the mechanism of his lacunar infarct. So for secondary stroke prophylaxis, it's going to be important to focus on his risk factors, the hypertension, diabetes, and smoking. He wasn't on an antiplatelet, so it's fine to start with an 81 milligram aspirin every day, as well as a high intensity statin. So that would be atorvastatin or rosuvastatin. Next case is a 70-year-old right-handed man with hypertension, diabetes, coronary artery disease. His family found him down at 6 a.m. with right facial droop, right arm and leg weakness, speech changes. His last known well, unfortunately, was at 11 p.m. when they put him to bed the night before. And he's coming into the ER at 7:30 in the morning as a stroke alert. So he's well outside the 4.5 hours. Blood pressure 167/89. Heart rate is irregular and a little tachycardic at 115. Glucose slightly elevated at 200. NIH stroke scale score is 14. So his is much higher. He has an aphasia. He has a complete right hemianopsia. So he has vision loss in the right fields in both eyes. He has right hemiparesis and right sensory loss. Here's his non-con CT. So a couple slices here. Really don't see much here. However, here we start to see maybe in the insula a little bit of a hypodensity. It's very subtle. And then even up in here, questionable, but it kind of looks symmetric. Right here is where I would pay more attention. Looks like he's starting to have some development of ischemia. And then on his CTA, this is a reconstructed image of that. You can see a cutoff of his distal left MCA, or middle cerebral artery. It should look like this one. So he has a cutoff there. So we suspect he has a large vessel occlusion, which is likely the cause of his symptoms and this area of ischemia that we're already starting to see. So he technically would be within the window for a thrombectomy, which is up to 24 hours. So patients should be treated with a mechanical thrombectomy if they meet the following criteria. If they're 18 or older, their pre-stroke modified Rankin scale score is a 0 to 1. So they had very minimal, if no, disability prior to the stroke. They were independent essentially. They have an ICA or M1 segment occlusion. If their NIH stroke scale score is 6 or greater and their aspect score is 6 or greater. So aspects is where you start with 10 and each area of hypodensity, you start to subtract 1. So obviously if they have a large area of stroke and their score is a 2, for example, it would not be wise to go in and try to perform a thrombectomy. There'd be increased risk of bleeding within that infarct. So the stroke cannot be very large in and of itself. Treatment, as long as it can be initiated within 6 hours, onset to grow and stick from their last known well, but we still extend it up to 24 hours to screen them for some patients. So that can be extended 6 to 24 hours for a select few of patients. This patient goes for thrombectomy. So this is the diagnostic cerebral angiogram. This is an AP view. So you see here this cutoff of the left MCA This is the internal carotid. This is the ACA, or anterior cerebral artery. Here's the device that they use. Here's the thrombus that they remove. And then you see restoration of flow into that left MCA. After they have a mechanical thrombectomy, they have to be on bed rest for 8 hours. We have to keep their blood pressure reasonable. The goal here from American Heart is less than 180/105, but typically our interventional radiologists and neurosurgeons like to keep it less than 140, in fact, even lower than that. So we get a 12-lead EKG throughout all of this on this patient, and it does show atrial fibrillation. So that is most likely his mechanism. So he had a cardioembolic stroke from paroxysmal AFib that caused that large vessel occlusion there. So we know that when it's safe from the stroke situation, safe from stroke standpoint, based on the size of what his stroke turns out to look like, if he ends up having any hemorrhagic complication after the thrombectomy, then we'll have to decide when it'd be appropriate to start him on anticoagulation for secondary stroke prophylaxis. Our next case is a 72-year-old right-handed man with hypertension, diabetes, and smoking. Presents with right facial droop, right arm and leg weakness, and slurred speech. Unfortunately, he's well outside 24 hours from his last known well. 170/95 is the blood pressure. He's tachycardic at 115, but it's regular. Glucose is 195, and nitro scale is a 12, so quite high. And on his non-con CT, you see here, we already see a large area of hypodensity that has developed. So he is, that does suggest he's at least several hours out, if not maybe more than 24 hours out. And then on his CTA of his head and neck, this is actually his neck, you see the right internal carotid artery, the right external carotid, you see the right and left vertebral arteries. And then over here on the left, where he's off center a little bit, so we're starting to just go through the bifurcation on this side. So this, in fact, is actually the left external carotid artery, and this tiny little bit of contrast coming through is what's left of his left internal carotid artery. And then this dark area around it is soft plaque, and then this bright area is hard calcified plaque. So he has a critical stenosis of his left ICA just as it's coming out of the bifurcation here. So most likely his mechanism is going to be atheroembolic. So likely he's had plaque rupture, maybe even some of this has embolized up into the head. So it didn't show in this case what the intracranial vasculature looked like, but I would be concerned that there would be a large vessel occlusion there as well. Sometimes you have a tandem occlusion where it goes all the way up, extends intracranially from the cervical carotid. Watershed can also occur from a stenosis like that, but it would be in more of a watershed territory distribution. So between ACA and MCA, it wouldn't really be down in here in the basal ganglia. So antiplatelet therapy, high intensity statin, maybe even consider dual antiplatelet therapy for a short period of time until we can get him to revascularization. Obviously, we want to avoid hypotension, so I don't want to drop his pressure too much so that he does, maybe he would develop a watershed infarction if we were to get his blood pressure too low, and then refer him to neurosurgery or vascular surgery to consider revascularization. So whether that's with a carotid endarterectomy or a carotid artery stent. I'm going to move on now to some potential complications of acute ischemic stroke. So cerebral edema in our larger, more lobar infarcts can be common. It affects up to 5%, and it's considered to have a significantly high morbidity and even mortality, depending on the size and the location. It usually peaks. I typically think about it peaking day 3 to 5, but it is beginning at 24 and up to 48 hours, all the way out to day 5. I've seen it happen even up to day 6 and 7. So it really does depend on the patient, how many collaterals they have, and also the size of the stroke. So the development of the edema is from failure of the sodium, potassium, ATPase pumps. You have disruption of the blood-brain barrier. You have both cytotoxic edema that develops early on, and then from the disruption of the barrier, you also have vasogenic edema, and it can also cause increased intracranial pressure as well. And by having herniation, it may even cause secondary brain ischemia, so it can cause compromise of other vessels in the head. So here is a patient with a large, pretty much the entire right MCA territory, ischemic infarct. So here's what the CT head non-contrast looks like. So pretty much the entire MCA territory has infarcted. Significant edema has developed. You're starting to see a little bit of mass effect here on this right lateral ventricle, maybe even able to measure a little bit of shift there, but it's very minimal, if any, at this point. And then here's the diffusion weighted imaging on the MRI, just shows you that bright area of restricted diffusion, and the same thing where we start to see a little bit of compression there. Now, these are what really scares me the most, are these posterior circulation strokes. So this is in the left cerebellum. Quite a large area of infarction there, and what worries us the most is compression on the brain stem. So for these patients, this can be an emergency. So what we want to do is we want to push up their sodium. So we may decide to do hypertonic saline, let it run 1.5%, let it run. You may want to even do 3% through the line, may even want to give the hot salt boluses. It depends on whether they have a central line or not, really what we do front, but we're trying to push the sodium 145 to 150. If it's significant amount of edema, I'll even try to push it up to 155. Checking that sodium at least every 6 hours, sooner if you're concerned about raising their sodium too quickly. Mannitol, we don't really use that often, but you can dose it based on weight. You can repeat it every 6 hours. All of these are really just temporizing measures, and so is hyperventilation. So moderate hyperventilation is reasonable for patients who are literally declining right there in front of you, but it's considered to be a bridge, not a definitive therapy. So you may be doing that while you're waiting to get them in the OR. And then hypothermia or barbiturates are not really used in acute ischemic stroke like they may be in brain injury. And then as far as surgical management, so this would be calling our neurosurgeons. So they have the best evidence to perform a surgery on patients who are 60 or younger, who have unilateral MCA infarcts, but also posterior circulation as well, who appear to either like they are concerned that they are going to deteriorate, or they are starting to deteriorate within the first 48 hours, despite best medical therapy, which would be the hypertonic saline or mannitol. Then it's reasonable to take them to the OR for a decompressive craniectomy. It does reduce mortality. It should be mortality there, close to about 50%. However, those patients can end up with pretty significant disability, but there's 55% achieve either moderate or even better than that. But you have to understand that if they're having to go for a surgery, it's because their stroke is quite large in the beginning. So this is the decompression is not only going to keep things from getting worse, but it can also be life-saving as well. So for patients who are over 60 years of age, who have meet the same criteria, then the craniectomy may be considered. But patients who are older tended to do poorly after surgery. All right, So here's an example. We have a 55-year-old right-handed woman, has hypertension, she smokes, has had 5 minutes of slurred speech and right facial droop, which have now resolved. Okay, this is getting into our TIA. Blood pressure is 158/85, heart rate is 70 and regular, glucose 115, NIH stroke scale score is 0, so she has returned to baseline. Her CT head without contrast showed no acute intracranial abnormality. She does have evidence, a little mild white matter disease. CTA showed scattered atherosclerosis throughout the head and neck, but nothing significant. So we diagnosed this lady with a transient ischemic attack based on her symptoms, and she has returned to normal now. It could be embolic or it could be a lacunar. It's most likely based on her history of symptoms that she gives and based on her underlying risk factors. I think it's most likely lacunar or small vessel disease. So treat that, we would treat her with a antiplatelet, a high intensity statin, and modify her risk factors. Now, if you hear that the patient had an aphasia or maybe a visual field deficit, it's hard to tease out neglect, but if a family member says, yeah, they didn't seem like they were paying attention to the right side, they kept bumping into the wall, all those things would suggest a cortical localization. So then you'd want to go more down the route of investigating an embolic source. So to help us decide how quickly we need to evaluate this patient or do their complete workup, we have the ABCD2 score. So it helps us to stratify the short-term stroke risk and TIA. So if their score is 3 or less, they're considered low risk. So even within the next 7 days, the risk is up to 6%, but obviously this risk goes up every week, 30 days, not significantly different, but then by 90 days, it is closer to 7%. But then if their score is greater than 3, they're intermediate to high risk. So you can see quite a difference in their risk of having a stroke just in the next couple of days is close to 10%. And so we always consider this. If we're concerned about an embolic source, for example, we may want to bring the patient in if their NIH is a 3 or greater to get an echocardiogram. If you don't suspect that, if you don't suspect an embolic source, and typically we already have our CT and CTA performed in the ER, you wouldn't have to admit this patient. Make sure that you get them on the right medications and you tee up all the risk factors, then they could be assessed on an outpatient basis. But if they do have a score of 3 or higher, they're high risk and you think it's an embolic stroke and it's not related to their vessels, so their CTA, head and neck looked okay, and you're worried about a cardiac source, then it would be reasonable to bring them in and do an echocardiogram, because if you were to identify a LV thrombus, for example, or a left atrial appendage thrombus, or they go into AFib, then you would be able to start an anticoagulant and significantly reduce their risk of stroke in the next couple of days and next 30 days. But this ABCD2 score, it accounts for their age, the blood pressure on presentation, their clinical features that they had, whether it was just weakness or just speech impairment, the duration that it lasted, and then whether they have diabetes or not. And so our patient had a score of 3. So they're kind of right at the cutoff where you could consider bringing them in. But since technically they're low risk, everything could be done outpatient if that's what the patient chose. And that's what you thought would be safe. And by outpatient basis, it means within the next few days, not within the next couple of weeks. All right, we have a 60-year-old woman, uncontrolled hypertension and smoking, comes in with sudden onset headache, nausea, slurred speech, left face, arm and leg weakness and numbness. She is not on an antiplatelet or anticoagulant. She's very hypertensive in the 200s. The rest of her vitals are appropriate. Glucose is fine. Her NIH is a 10.
Dr. Swafford, this is just a reminder, we will need to finish up in the next couple minutes. We have residents that need to get to clinic.
Absolutely, absolutely. You just let me know when you guys have to go if I'm still talking, but hopefully I'm about to wrap it up.
Thank you.
Thank you for reminding me. So this is a non-con CT head. You see this hyperdensity in the right thalamus. On the angiogram, there was no vascular malformation or aneurysm. So this is a pretty straightforward bleed within the thalamus, which is a common location for when it's secondary to hypertension. So it's going to be really important in ICH to manage the blood pressure. Typically, we like to keep it 140 or less. For patients who are coming in greater than 220, you may want to slowly bring them down to that, but as safely as and quickly as possible, because we know bleeding can worsen when the patient blood pressure is uncontrolled. If you recognize that they were on a vitamin K antagonist like warfarin, then their INR is elevated. So typically greater than 1.5, we want to reverse that with you can give PCC, which is prothrombin complex concentrate, which replaces their factors that are affected by warfarin. But you also want to consider giving them vitamin K. You can also think about giving FFP, but it does take quite a while. And we actually prefer PCC over that if it's available. If they're on a DOAC, so rivaroxaban, apixaban, typically here at UK, we give them the PCC as well. For heparin and Lovenox, protamine is given. And then we really don't have good evidence to support the transfusion of platelets if they're on an antiplatelet. However, if they are going to go for surgery, maybe a hematoma evacuation or hemicranie, I know that neurosurgery may elect to transfuse platelets. And then so for this lady, most likely her mechanism is uncontrolled hypertension. So to treat that, it's just going to be very strict blood pressure control. And then I think these might be the last two slides or last few slides. So as far as primary stroke prevention, there are things that we can't really modify, like patient's age. Low birth weight has actually been associated with increased risk of stroke, patient's race or ethnicity, and then certain underlying genetic factors that we may not be able to control. But there are lots of modifiable risk factors. So hypertension, hyperlipidemia, diabetes, AFib, and other cardiac conditions, recognizing asymptomatic carotid stenosis and doing something about it before it becomes symptomatic, sickle cell disease, smoking, physical inactivity, diet, nutrition, and obesity are all targets that we can focus on. And that's all. Does anybody have any questions? I know we're last minute.
Thank you very much. We really appreciate it.
You're very welcome. You're very welcome.